Welcome to the webinar on autoimmune hepatitis. I'm Farah Douglas, President and CEO of the Liver Health Foundation. Autoimmune hepatitis is a chronic and inflammatory liver disease characterized by the immune system attacking healthy liver cells. In this disease, the immune system mistakenly targets and destroys healthy liver cells rather than foreign objects. Some people with autoimmune hepatitis may not have symptoms until complication arises. One of the Liver Health Foundation's liver stars, Alyssa McCarthy, was diagnosed with autoimmune hepatitis when she was 12 years old in 2019. She has been through the full range of diagnoses and treatments since then, from biopsy until this year that her enzyme levels began to increase. With all the ups and downs of autoimmune hepatitis, Alyssa is very active in sports and theater. We hope today's information helps our Alyssa and other autoimmune hepatitis patients. Autoimmune hepatitis is a rare liver disease. Liver Health Foundation is proud to host these free educational webinars to raise awareness of liver disease and to educate patients. We are a patient advocacy 501c3 nonprofit organization with the mission to support liver patients, their caregivers, and family members. We operate in Los Angeles, Inland Empire, Orange County, and portions of Arizona and Northern California. In tonight's webinar, Dr. Lily Dara will offer a comprehensive review of autoimmune hepatitis through a PowerPoint presentation. At the conclusion of the presentation, we will begin a roundtable discussion with Dr. Dara, Dr. Georgiani, and Dr. Robert Gish. During the roundtable discussion, our experts will talk about their own experiences in working with autoimmune hepatitis patients and/or their research on this disease. If you have any questions, please use Q&A or chat functions and post your questions. Our experts will try to respond to all questions. Please remember, information given by our expert is not a substitute for advice given by your own physician or healthcare provider. We do not endorse doctors, hospitals, medical centers, or treatments. This program has been made possible by an educational grant from Epson Pharmaceuticals. We thank Epson for their support. I am honored to introduce Dr. Lily Dara, who has generously agreed to be the presenter for tonight's program. Dr. Dara is an assistant professor of medicine, Department of Medicine, Division of GI, Liver, USC Research Center for Liver Disease, Keck School of Medicine, USC. Dr. Lily Dara is an NIH-funded physician scientist at the University of Southern California with a research interest in drug-induced liver injury and autoimmune liver diseases. She is a graduate of Shahid Beheshti University of Medical Sciences in Tehran, Iran. She completed internal medicine residency at Griffin Hospital, a Yale-affiliated program in CT, and gastroenterology fellowship at the University of Southern California in Los Angeles. She became interested in liver disease during her residency as she was particularly fascinated by drug-induced liver injury and hepatotoxicity. After seeing several cases of hepatotoxicity due to dietary and weight loss supplements. She is currently a tenure-track assistant professor of medicine and studies mechanism of liver injury and hepatotoxicity with a particular focus on immune checkpoint inhibitors using basic animal model and translational approaches. Clinically, she's interested in the complex presentation and difficult treatment of autoimmune hepatitis and PBC, and the variant syndromes, particularly in the underdeserved and minority Latinx population in East Los Angeles. Dr. Dara, welcome to Liver Health Foundation's educational webinar. I believe this is the first time you are participating in our webinars. Thank you for your support. We are ready for your presentation.
Thank you, Farah. Thank you for inviting me. This is different than what I normally do. It is actually the first time I am speaking to a large group of patients. So I'm super excited, and I've prepared this talk specifically with patients in mind. So that's me. That's USC. We're on the east side of LA. We have a large hepatology practice. We do over 150 transplants a year. Besides me, there's two other hepatologists, Dr. Khan, who I think is doing a webinar for you next week, Dr. Kamichian, who specifically are interested in autoimmune liver diseases. Patients can reach out if they have questions. If they're looking for referrals in LA, I'm happy to help them. This is my email, and I am on Twitter as well. I have some disclosures. They're minor, but they're related to autoimmune liver disease. So I've done consulting for these two companies in the past related to actually this disease and similar diseases, right? So what is autoimmune hepatitis? AIH is a chronic inflammatory and autoimmune disease, as you so elegantly pointed out, Farah. It is a disease where immune cells and antibodies which normally are supposed to attack bacteria, viruses, and other pathogens, attack the body mistakenly. So they go haywire. And this can be through an attack of the actual immune cells attacking the liver, or the immune cells secrete compounds called antibodies, and the antibodies mediate an immune attack on the liver. And so why is inflammation in the liver bad? The reason for that is because inflammation leads to liver cell death. The hepatocytes in the liver start dying because of the immune cells coming in and secreting all the nasty stuff. And as a result of cell death and dropout, you get scarring or fibrosis. And this becomes a vicious cycle wherein inflammation begets cell death begets inflammation, and you end up scarring, and replacing eventually your normal healthy tissue with scar tissue or collagen. Who does autoimmune hepatitis affect? Autoimmune hepatitis can affect all ages and all ethnic groups. Even though it was first described in white women, it is a disease that people of all ethnicities can get. It can also affect men. So it affects men and women, a higher ratio in women, but certainly I have a lot of male patients as well. Non-whites have a more severe course. We know that Alaskan natives have a higher frequency of being jaundiced and yellow when they present. Hispanics more commonly present at a later stage when they're already cirrhotic. And Blacks have an accelerated progression and a higher rate of recurrence post-transplant. How common is autoimmune hepatitis? What's interesting is that even though it's still considered a rare disease, incidence is steadily going up over time. And this holds true for all autoimmune diseases, okay? For lupus, even the presence of positivity for ANA, anti-mitochondrial antibody, when you look at the general population every decade, it's steadily going up. So autoimmune diseases are increasing. And at least there's been a 50% increase over the past few decades. Like I said, female predominance, female sex predominance, XX, there's a 4-to-1 ratio compared to XY. There are two peaks, one in early adulthood and the second in the 60s and 70s, as you can see on the graph on the top right. The range depends on what country you look at and what statistics you look at, anywhere between 4 in 100,000 to 40 in 100,000, which is the Alaska Native populations. And the incidence occurs at about 0.6 to 2 per 100,000 persons. So what causes the autoreactivity in autoimmune hepatitis? Patients often ask me, like, why do I have this? And unfortunately, the answer is we really don't know. We don't know what actually is the trigger for the immune attack on the liver. We do know that some people have genetic susceptibility, and we do suspect that there's an influence on environmental factors. Some have suggested a role for viruses and, childhood infections with viruses, or you get a viral infection and that triggers the autoimmune response. What we do know is that autoimmunity is hereditary and it runs in families. And in addition, there are some drugs that cause an autoimmune-like hepatitis. And these drugs famously are nitrofurantoin and minocycline, although infliximab, statins, hydralazine, alpha-methyldopa can do this. And there are many drugs, a whole host of list of drugs that can cause this. But key here is that if you get a drug-induced autoimmune like hepatitis, you stop the drug. Sometimes you need a short course of steroids, but the inflammation resolves and you don't continue to have autoimmune hepatitis. Whereas when you have genetic or what we call de novo or idiopathic autoimmune hepatitis, your inflammation continues without treatment. So what are the symptoms? If you have autoimmune hepatitis, you're already familiar with this. When patients present to us, about a third of them have no symptoms. A third of the patients are just picked up on lab abnormalities. They go to their primary care, they get their blood drawn, and we see that they either have already a diagnosis of cirrhosis, or they just have early stages or mid stages of inflammation and ongoing chronic inflammation. Patients usually have mild and vague symptoms. Fatigue is one of the biggest ones, followed by anorexia, weight loss, abdominal pain, and even fever. Joint pain and transient rashes can also occur. And unfortunately, some patients even have persistent symptoms on treatment. About a quarter of patients present with an acute flare. So their first presentation results in a hospitalization. They don't feel well, they're nauseous, they go to the ER, and their AST, ALT are in the thousands or hundreds. Usually these patients are not in liver failure, they just have a very severe presentation. But of this 25%, there is another subset that actually present in full-blown liver failure, which is very serious. These patients are yellow in the eyes, they're jaundiced, they're encephalopathic and confused, and they have coagulopathy, which is a blood clotting problem. Patients with autoimmune hepatitis can have other autoimmune diseases. And we see this between, in between 14 to 44% of patients. So almost half have something else going on. And the most common one, the number one, is Hashimoto's thyroiditis, which is hypothyroidism, which is very common in patients with PBC. In patients with AIH and also in patients with PBC. The other liver diseases, PBC and PSC, can also co-occur in patients with AIH. Celiac disease, which is a disease where you're not only gluten intolerant, but you form antibodies to it, and it's a very serious autoimmune disorder, can also occur in AIH. And actually screening for both thyroid disease and celiac disease is recommended if you are diagnosed with autoimmune hepatitis. Other than that, you can get rheumatoid arthritis, diabetes. Type 1 diabetes occurs with type 2 autoimmune hepatitis. Vitiligo, inflammatory bowel disease, and hemolytic anemias, which are also autoimmune, can be seen. And so I just mentioned type 2 AIH. What am I talking about? AIH classically occurs as two variants. Type 1 AIH is the classical variant. Most of the patients have this type of disease. In these patients, you have an anti-smooth muscle antibody that's positive or an anti-nuclear antibody that's positive. Type 2 AIH is rare. It occurs in children. It is often more severe. And the hallmark for type 2 autoimmune hepatitis is a specific antibody called anti-liver kidney microsome type 1 or LKM1. And in addition, anti-liver cytosol or LC1 can also be seen. What is the workup for autoimmune hepatitis? In autoimmune hepatitis, we always send a few specific tests. One is the autoantibody panel. I mentioned anti-nuclear antibody, anti-smooth muscle antibody. We check an anti-mitochondrial often because sometimes the diseases co-occur. I personally always check a serum IgG and a serum IgM to follow treatment response. A serum IgG is elevated in autoimmune hepatitis. A serum IgM is elevated in primary biliary cholangitis. If these above tests are negative, I order then an LKM1 because an ANA and an LKM1 don't occur at the same time. So following that, we check the more specific antibodies, LC1, anti-soluble liver antigen, PANCA, etc. One of the things I want to point out here is that your doctor knows what test to order. But what's fascinating is that about 20% of our patients, so a fifth of them, will be what we call seronegative AIH. So if you have AIH, it doesn't mean that you have to have one of these autoantibodies. It's just that the majority of patients display one of them. And so one of the questions we sometimes get is, why do I need a liver biopsy? And why is the liver biopsy always necessary? And the answer is, it is a tricky disease. We don't even know what the antigen is. And there's no combination of these autoantibodies and blood tests that can make the diagnosis for you. So you always need a liver biopsy because once you receive the diagnosis, you are committed to lifelong immunosuppression. So if you're going to put somebody who's in their 20s or 30s or 40s or 50s even for another 20, 40, 50, 60 years on immunosuppression and try to bring down their immunity, you really want to be sure you've nailed the diagnosis. So a biopsy is necessary in this case. Also, when we get a biopsy, we see how much fibrosis there is. And based on that, we decide, do we need to be careful and monitor you for hepatocellular carcinoma? What is your risk? So we can prognosticate and risk assess you once we know the level of fibrosis or scarring. I'm going to use these terms interchangeably. When I say fibrosis, I mean scar tissue. And the other reason, honestly, is that the level of AST, ALT elevation doesn't always reflect how much injury is in your liver. It doesn't tell you the activity. So why do we do this? Why do we need the diagnosis? It's because we want to provide therapy, right? And what is the goal of therapy? The goal of therapy in 2024 is normalization of IgG and transaminases. We want your AST, ALT, and IgG to be rock solid normal. I don't want it to be 1.5 times the upper limit of normal, 2 times the upper limit of normal. I want your AST, ALT to be normal. And sometimes if you see specialists like me who are really like deep versed into this world, we may throw around a term like CBR. CBR means complete biochemical remission. So the patient is in CBR if the IgG is normal and the serum transaminases are normal. And so what is therapy? Therapy is basically immunosuppression. Immunosuppression is prednisone plus a steroid-sparing agent. In the first phase, we induce remission with prednisone or budesonide. Budesonide can be used in children and non-cirrhotics. In phase 2, we want to maintain this remission. And so we start steroid-sparing agents such as azathioprine and mycophenolate, which are the most commonly used first-line agents. And then we start coming down on the steroids. 3, and this is key, there's a lot of diseases where we don't have such beautiful data. But 3, randomized controlled trials, placebo-controlled trials, have shown improvement in survival with steroids versus placebo. So taking immunosuppression and steroids in particular, steroids and azathioprine is what has been studied most, improves lifespan, makes you live longer. What are steroid-sparing agents? You hear us throw this term around a lot. We're going to use a steroid-sparing agent for you. These are agents that are used for immunosuppression that allow us to decrease the dose of prednisone to hopefully eventually get you off of prednisone. Because as much as we want to immunosuppress you, we don't want to keep you on long-term prednisone. No doctor or patient wants that. Unfortunately, there are some patients who are steroid dependent and really need prednisone. And in those cases, we try to maximize the steroid-sparing agents so we can minimize the prednisone. Try to get it to a sub-physiological level, which is usually below 7.5 milligrams a day. So now between the first-line agents, there's some benefits to azathioprine versus mycophenolate. You have to individualize this, what's best for you, and make this decision with your doctor. But just generally speaking, the dosing with azathioprine is once a day, whereas a mycophenolate is twice a day. AZA costs less. Most centers have more experience with azathioprine. And you can't give azathioprine in advanced cirrhosis. With mycophenolate mofetil, it's better tolerated. It's a little bit less in the side effect profile, a little less nausea, a little less bloating and belly pain. It acts a little bit faster, so you can taper the steroids faster. The main problem with mycophenolate is that I have a large cohort of young women who want to get pregnant eventually, and young men. And it's very problematic to give somebody who wants to get pregnant mycophenolate unless they do 2 methods of birth control. It causes fetal anomalies. It is what we call teratogenic. It also gets secreted into milk, so lactation is a problem. And even in men who want to reproduce, if they're taking it, it screws up their sperm, so they can get congenital anomalies in the offspring. So common side effects. I knew that I was going to get this question, so I put it in there already. The questions about side effect, these are the mainstay of therapy. There are many other drugs we use, but this is what we use mostly. For steroids, it's always the same. Steroids cause weight gain, diabetes, mood changes, osteoporosis, and acne. Not fun, right? But if we can minimize it, we can minimize these side effects. And again, the reason I showed you the data on survival is for you to understand that if your doctor tells you need to be on steroids, it's because it's important for your liver health. With azathioprine, the most common side effect is GI upset, nausea, diarrhea, just, not being able to tolerate it GI-wise. It also can drop your white blood cell counts and red blood cell counts, predominantly white blood cell counts. So you need to be monitored while you're on the drug closely. It can cause hair loss, rash, and muscle pain, among other things. These are just some of the top side effects. There are more side effects. I'd tell you to look it up on the drug's label. The mycophenolate, it does also cause GI upset. It's a little bit less. In my experience, patients tolerate it a little bit better. But it can also cause edema and diabetes. And all of these drugs, I should say, can cause infection because they're all immunosuppressants. And so I already kind of alluded to this. Why is it important to be treated? And why is it important to stay in remission? This is a very old study. It is from the 70s, but I just want to point out here that on the right side, you see patients who were treated with placebo, right? And then patients who were treated with prednisone or combination prednisone and azathioprine. And you can see that 70% of patients that didn't get treated, the placebo arm, went on to develop end-stage liver disease and cirrhosis within 2 to 3 years. Now, the good news is that if you do get treated, even if you don't normalize your AST, ALT, and numbers, even if you don't normalize, but you just improve, which occurs in 90% of the patients, the rate of fibrosis is reduced by 50%, meaning that even with an incomplete response, there is benefit, right? We say the lower, the better, but if we get your AST, ALT down even somewhat, you're going to have a better outcome than not getting treatment. So a little bit about relapse and flares. One of the reasons we don't take off the drugs and the therapy is that when we do, about half to up to 80% of patients will flare when the drug is withdrawn. Every time you flare, every time that AST, ALT goes up, you get inflammation in the liver, you get hepatocyte cell death, and you get scar and fibrosis deposition. So we want to avoid flares. And even patients who have a histologic remission, meaning you've been on the drug for 2 years, we do a biopsy, it looks beautiful. There's nothing there. There's no inflammation. You've just been on 50 milligrams of azathioprine for 2 years. And we say, okay, let's bite the bullet. Let's try taking them off. Even in those patients, 30% will relapse. So it's a tricky disease. So most of our patients end up needing lifelong immunosuppression. And the goal really is to minimize steroids and find the least toxic, best option for immunosuppression. Why people relapse is not clear. There has been associations with certain HLAs, which is the genetic association. Men seem to relapse more. And apparently, if you're on therapy for a shorter duration of time and you try to quickly come off of it, you're more likely to relapse. This is just my last slide about historical perspective, about the fact that honestly, we have known about this drug since the 1940s. It was described by Waldenstrom, and there's papers from Zimmerman and Reynolds and Redeker, as you can see there, who Redeker was one of my mentors, and going on to Sheila Sherlock. Multiple trials back in the 40s, 50s, 60s, 70s, and we're still in 2024 talking about prednisone and azathioprine, which is baffling to those of us in this field. because there's really not a lot of great treatments out there. Whereas we see in comparable fields like inflammatory bowel disease, there's an explosion of like biologics and, other therapeutics for immunosuppression. So the question is, what's on the horizon? And the good news is, over the past 5 years, there have been at least 3 clinical trials that have enrolled and have had some positive data. And we're hopeful that there'll be newer trials available for patients. The AMBER trial closed enrollment. Phase 2 of the Portola trial of zetomipzomib also closed. And a few years ago, there was a toll-like receptor, JKB122, a TLR4 agonist that was tried and apparently had positive results, but that's been kind of like MIA since 2022 when another company bought the company that was doing that trial. So right now we are in a phase where we're hopeful that new trials come out. And it would be very helpful for patients to get involved and advocate for this. We're all advocating for it all the time, and I'm happy to take your questions now and start the roundtable.
Thank you so much. I appreciate it. This was a great presentation, a lot of details, and some of the questions that I already had received, you just responded to a lot of them. So now in this section, we are going to start the second half of the program, which is the roundtable. And the purpose of the roundtable is that our doctors get a chance to talk more about this disease and exchange ideas and talk about their own experiences in working with the autoimmune hepatitis patients. So I will introduce the other. You have already met Dr. Dara, so I'm going to introduce the other 2 doctors who will be helping us at the roundtable discussion. It is my distinct honor to introduce Dr. George Yanni, who is a familiar face to our audience for his past participation in our educational webinars. George Yanni, MD, FAASLD, is a professor of clinical pediatrics, USC Keck School of Medicine, Associate Director, Pediatric Liver Transplant Program, Transplant Hepatology Fellowship Director, Division of Pediatric Gastroenterology, Hepatology, and Nutrition, Children's Hospital, Los Angeles. Dr. Yanni has been Medical Director and Associate Professor Pediatric GI at Loma Linda University Children's Hospital, attending Pediatric GI at Riverside County Regional Medical Center, Clinical Professor Pediatric GI at Keck School of Medicine, University of Southern California. Some of Dr. Yanni's other titles include Interim Medical Director, Transplantation Institute, Loma Linda University Adult Liver Transplant Program, Hepatology Fellowship Director of Pediatric Gastroenterology, Children's Hospital, Los Angeles, and Director GI Endoscopy Services, Division of Pediatric Gastroenterology, Hepatology, and Nutrition, Children's Hospital of Los Angeles. Dr. Yanni's major areas of research and interest are pediatric liver disease, gastrointestinal and hepatic autoimmune disorder, transplant immunology, pediatric NAFLD, obesity, pediatric gastrointestinal procedures. Dr. Yanni, welcome. We appreciate your continued support. I am pleased to go ahead.
Thank you, Farah, for this kind introduction. It's a pleasure, and I'm very humble with your introduction, and I'm honored to be part of the team helping out in.
I appreciate it. Thank you so much for your continued participation in our webinars. Now I will introduce our other participant, Dr. Robert Gish. He is Adjunct Professor of Medicine at the University of Nevada, the School of Medicine in Las Vegas and Reno, Adjunct Professor of Pharmacy at Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD, a Clinical Professor of Medicine at Loma Linda University, medical director of the American Pacific Health Foundation in San Diego and of the Hepatitis B Foundation in Doylestown, Pennsylvania. Dr. Gish is a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and the American College of Physicians. He has served on the editorial boards of American Journal of Gastroenterology, Hepatology, Journal of Hepatology, Digestive Diseases and Sciences, and Gastroenterology. He has co-authored a public health policy for liver health in Vietnam, focusing on HBV, and is also assisting with the development of viral hepatitis healthcare policies in Georgia, Armenia, and the Philippines. Dr. Gish is well respected and well known as a major early contributor in deciphering methods for the detection of hepatitis B and C virus and characterizing its epidemiology and clinical presentation in humans. He was involved in the studies that led to the genotype classification strategies and methods now in use worldwide. He has published more than 700 original articles, review articles, abstracts, and book chapters. Dr. Gish is currently seeing patients both in person and via telemedicine at various clinics in San Diego, Folsom, San Jose, Santa Rosa, Las Vegas, Reno, and via telemed to you. Dr. Gish, welcome to the Autoimmune Hepatitis webinar. Thank you for your continued support of our efforts.
Great, glad to be here. Thank you.
Thank you. Over the past few days, I have received questions from the audience as well as those who couldn't be with us tonight. I have submitted the question to our presenters to review and to respond. However, the audience members are also welcome to put their questions in Q&A or chat tabs, and our expert will try to respond to them. To start the roundtable discussion, I would like to pose a question that was repeated several times. The question was, does autoimmune hepatitis remain active post-liver transplant? Dr. Dara, would you like to comment on this?
Yes. So recurrence post-transplant, and I'm sure my colleagues here can also comment, is not uncommon, unfortunately. Even though, for transplant, we use some of these same drugs to prevent recurrence, some patients really end up needing prednisone post-transplant. And I would say about a 30-40%, in my experience, end up needing, but not everyone. So you may be part of the lucky few that won't need prednisone. But even if you do, I think post-transplant, because we use a lot of calcineurin inhibitors, we can control the disease pretty well. Bob, do you have any thoughts on this? I generally like Tacro for AIH. I think it works pretty well.
Yeah, I'm a big believer post-transplant in TAC and mycophenolate, and I'm a big believer in checking mycophenolate levels. This comes from some research and other solid organ transplants. So if you use the right dose of mycophenolate, you get a trough level in the 2 to 3.5 range. I think most people, I'd say 95%, can get off prednisone. And I use that mycophenolate dosing and levels in my autoimmune hepatitis patients. I haven't started anybody on azathioprine, I don't know, in a decade. And I agree with your concerns about pregnancy and et cetera. And of course, I do that informed consent. I guess my patients are older than yours, Lily. I don't know why.
Oh, yeah, because I have a lot of young women. I mean, obviously, if someone's in their 50s, I'm just like, let's just do mycophenolate. But it's also a cost issue sometimes, because I also practice at the county. And it's just, and if you can tolerate azathioprine, there's nothing wrong with azathioprine, right? It's just easier to manage mycophenolate.
I've had pancreatitis, bone marrow suppression, GI tox. You have to do TPMT. Yeah, I would say
you have to do TPMT for sure.
Yeah, 1 out of 5 of my azathioprine patients, which was over a decade ago, had some adverse event. Mycophenolate, I've had no adverse events as long as I followed levels.
Yeah, they do get sometimes nauseous. They sometimes do get some like GI stuff, but it's usually more minor. I agree. I don't know, George, in kids, if you have a preference, and I don't know what the recurrence rate is in kids post-transplant, but we see about 30-40%.
Well, thank you. First of all, thank you for your amazing presentation, Dr. Dara. Really enjoyed it. In pediatric population, the story is a little bit different. I'm afraid to say that because like most of our transplant population who are get transplanted for autoimmune hepatitis, that like the majority of them, I will say, probably teenage girls with like very, very few teenage males. And using mycophenolate, it's kind of very, very risky because, as you
Yeah,
know, in teenage girls, we don't know when a teenager can get pregnant. And we really,
it's super fertile.
yeah, and we have a large population actually of even the who got transplanted from other causes, they form what we call it de novo autoimmune hepatitis post-transplant, basically based on a biopsy and elevated IgG and elevated autoimmune marker. So if we know, if we have a known patients who she present with burned up autoimmune hepatitis or acute liver failure, as you said in your presentation, and they have been underlying or the explant showed evidence of autoimmune hepatitis. We probably they continue as far as we would like them to be off the steroid after the transplant in the first 6 to 9 months. We would like to keep them in a very low dose, sometime between 2.5 and 5 milligram, which is very, very low dose, but they respond very well. We have a handful of patients. They continue to be on azathioprine after the transplant because you want to protect their kidney from the effect of the tacrolimus.
Yeah.
So we use the kidney sparing, steroid sparing protocol, just run them on triple immune suppression, which is like we have the patients really, really very, very refractory to treatment, and they need aggressive medical therapy, especially as you said, in the African American diversities where they have very, very high
A lot of
recurrence.
recurrence.
Yeah. So this is basically the perspective from the pediatric side.
Very,
Um,
very interesting.
We had the question that I talked with, I believe, Dr. Yanni before we started. It's a question from a liver transplant patient, and Dr. Yanni is advising me that because the question is so particular to that one person, that it's much better for him to contact his own transplant doctor and surgeon and try to find solution. I just wanted to mention it, so I don't want people to think that we don't pay attention to their questions. So, Dr. Dara, you spoke about the long-term effect of autoimmune hepatitis on the liver and the risk of developing other autoimmune diseases and cirrhosis. So I'm wondering if you want to add something, and also if Dr. Gish and Dr. Yanni want to add something to that. We
I
have a
had not
question.
seen the questions, but I was kind of
Okay,
anticipating people would ask those. That's why I
yes,
cover
you
them.
did
And in
very
20
well.
minutes, it's such a big topic. I can talk about this for 3 hours, but in 20 minutes, you're just hitting the highlights. I don't know if Bob or George have anything to add, but yeah, I mean, they definitely should get checked for other autoimmune diseases. The ones that it's recommended to get screened for is thyroid mainly and celiac, especially if you're white, if you're like a Caucasian white person. And then it runs in families. So if somebody in your family has lupus, you're more likely to get it. It seems to be the case. And then the effect, I think I made it pretty clear that, as long as we can control that flare, as long as we can control the inflammation, you're not going to progress your liver disease. So that's why it's really important to be compliant with therapy. And I know it's hard. I know it sucks to be in your 20s and have to take immunosuppression and steroids. And
Yes.
Bob, what do you think?
I think all your points are great. The celiac is something that's missed very commonly, and also in PBC, primary biliary cholangitis. I don't see it much in PSC, but that is something that's just so easy. Just do an antibody panel, check for iron deficiency, talk about diarrhea or malabsorption, super key issue. But there's other diseases. I just had a patient who I sent to UCSF from Santa Rosa, where I'm sitting right now, who looked like they were in fulminant liver failure from autoimmune liver disease. And they started with CREST, and then suddenly the liver enzymes went to 500, bilirubin went to 12. We were able to rescue that person, fortunately, with mycophenolate and budesonide. Budesonide is my favorite to use, but of course, we don't use that in people with cirrhosis and portal hypertension. Fortunately, this patient didn't have cirrhosis yet. So was rescued with budesonide, but then had some problems with abnormal electrolytes. And
You induced remission with budesonide? You put with ALT of 500, or you induced it with prednisone and switched to budesonide?
No, when on budesonide, enzymes went from 600. I just talked to the patient today with ALT at 60, 600 to 60 in about 7 weeks, which is fantastic. But the next twist on this was lower blood pressure and abnormal electrolytes, and also his autoimmune adrenal insufficiency. And we had to switch from budesonide today to prednisone because budesonide doesn't get into the circulation very much. So it was complicated. So there is this whole family of autoimmune disease. This is one of the first times I've seen adrenal insufficiency from autoimmune. But that's something else. Adrenal are these glands that sit on top of the kidneys that regulate electrolytes and blood pressure.
And cortisol, your flight and fright. Is that the polyglandular autoimmune syndrome kind of situation? Yeah.
That's the next workup that's going on top of CREST and liver disease.
Yeah, very interesting. George, I wonder if like in the kids you see this commonly with like diabetes or celiacs, the co-occurrence.
Yeah, we've seen that we always screen for celiac as in your presentation, and I agree with you 100%. It is a very tricky disease, and parents or patients need lots of education on every single visit. And for the last few years, 5 or 10 years, we're starting to see another entity, which is immune dysregulation. And believe it or not, I mean, we always advise a patient to seek expert people in this disease because like 7 years ago, I got two patients who got this immune dysregulation, and they were diagnosed with autoimmune hepatitis, and they were placed on prednisone and azathioprine. And after a while, I mean, we discovered that this was triggered by immune dysregulation, was mistakenly diagnosed for autoimmune hepatitis. So I think physician and patients need to be very aware that when you do the diagnosis, exactly as you said in your presentation, you need the liver biopsy, you need the blood test, and to make sure that you're treating the right disease and not misdiagnose them, because at this point we have seen fulminant liver failure patients coming to the hospital, especially in pediatric, with what's you call it immune dysregulation. And we have a protocol in Children's Hospital. We put it 4 years ago by one of my fellow. She is an amazing fellow, Dr. Victoria Shaheen. Now she's practicing in Michigan. She's associate director.
Vika Shakeen?
Vika Shaheen, yes.
Yeah, she's on the Dylan Network with me. I know she works with Bob Fontana. She's fantastic.
She is fantastic. I wanted her to stay with us, but she wants to be very close to her family in Michigan. So she's the one who started this protocol in immune dysregulation, with treating with high dose steroid and weaning it off, tapering it off over a period of 10 to 12 weeks. And usually we get CD, some special stain on the liver biopsy. Some other kids, they really presented with impending liver failure, liver enzyme getting very badly progressed. And when we got a very small window, we got a biopsy, we showed us slam dunk features of autoimmune hepatitis. We treated them. We were able to turn them around very quickly with the steroid and azathioprine, and then you're doing fine. So they need to be continued to be monitored closely, at least every 3 to 6 months with blood tests, with surveillance lab. And we were not saying to get a liver biopsy every 5 years, like post-transplant, but at least you need to keep the liver enzyme normal.
Yes. I need to
Um,
look this up. I don't know anything about this entity that you see in children.
One of the other questions we had, people were asking, are there any lifestyle changes or diets, exercise that can help us manage autoimmune hepatitis better?
I have to, I'm sorry, Dr. Dara, go ahead. I don't
No,
want
please
to,
go ahead, please.
but, but I see this in pediatric because we have right now, you can see as you saw in the ASLD this past weekend in San Diego, there were the major two topics were either fatty liver or the IBAT inhibitor or the cholestatic liver disease. So in we have an pandemic of obesity in pediatric population, especially with fatty liver disease, and we are getting like major referral jump in pediatric with obesity. You put someone in prednisone, especially high dose prednisone initially at the beginning of the disease treatment, is starting to gain weight a lot, secondary to the prednisone as side effect. So the parents or the patient need to be aware that they need to have a lifestyle modification and diet modification style, avoiding the sweet stuff, the salty stuff, too much salt, because it's with the prednisone they will retain water and they make the body swell up. The side effect of the prednisone can include diabetes, so they have to be careful about the sugar and the sweet stuff, in addition to the side effects, so they don't gain weight and they don't exacerbate the disease. Because we sometimes you control the serum autoimmune marker, we brings them to normal, but the patient starting to have elevated liver enzyme secondary to NASH.
Yeah,
So this is a big problem.
completely agree. Bob, do you
Yeah,
have any comments on diet, exercise?
always healthy.
Always healthy. But yeah, the main thing is that, you know, once you're on these drugs, you can have kidney toxicity, you can gain weight, you can get diabetes. So you have to really watch your salt, watch your sugar, watch your fat. It's just, you just have to eat healthy. California diet, okay? Like salad
This
and
We have to think about the whole patient. That's what we do every day. That's why being a hepatologist is a big project. You're not just a liver expert, which is, like we just found out, it's overwhelming from ASLD. But we have to back up. A lot of primary care providers, pediatricians, adults just run the other way when they hear the word liver. They get paralyzed.
this young girl that young lady that I talked about, who is our liver star, one of the things, two things really bothered her the most about having autoimmune hepatitis. One was biopsy that they did. And the other one was the extra weight that she put on, because she felt at the school, people were pointing at her, and it was just a very horrible time for her to go through it. And she did go through that, and she's much really fit young lady and doing very active. But there is nothing you can do about those two things, right? Is that the best way, the best method of diagnosing autoimmune hepatitis? Is it still biopsy, or is that the last resort?
Biopsy, biopsy, biopsy. Lily, summarize that.
Yeah.
Always a biopsy.
You need a biopsy, Farah, because otherwise you're going to put somebody, like, if you're not 100% sure, how can you put him on, how can you put that 16-year-old on immunosuppression for 60 years, 70 years, you know, however long her lifespan is, 80 years. Hopefully she'll live to 100.
But Lily,
Sure.
we need to give them hope. I never use the words lifelong for hepatitis B treatment. I never use it for autoimmune. There are people doing research. There's some other
We'll get to
clinical
that
trials.
point.
There's a number of clinical trials that are going on. They're kind of hidden in the background, even though there aren't any major breakthroughs. Trying to remember the company in San Francisco I work with. It's the name of the company that's based on that racetrack just below UCSF, but I'll think of it in a minute. There is hope.
It's interesting you mentioned those two things because I have two questions and I'm going to put them here as one. One is there any kind of vaccine or research that's being done to prevent autoimmune hepatitis? And the other question is, how can I enroll and participate in clinical trials and research on autoimmune hepatitis? So please respond, any of you.
Kezar is the company I work with in San Francisco. They've got an interesting drug that they're hoping
No, I
will.
mentioned it, Portola. Yeah, they're not enrolling right now. They just closed, but they are hopeful to start
Right.
phase 3. USC was a site for it. Were you a site for that too, Bob?
I'm on their DSMB. I'm watching everything.
Mm-hmm. Just for the Portola, right? Not for the kidney stuff, not for the lupus.
Yeah, but we hear about all the kidney things.
Yeah, it looked good in the hepatitis so far. So
Good point. Thank you.
And there is no vaccine, Farah. This is autoimmune disease. There is no vaccine for autoimmune disease.
Which brings up a good point that I've seen a couple of cases of vaccine-induced autoimmune hepatitis, but I've been watching this giant, database out there, and I'd say that risk is about 1 in a million. So
very low.
Yes. The vaccines are very safe. COVID vaccine. I've had 9 COVID vaccines myself. I just had 2 monkeypox. I've had RSV. I'm getting yellow fever in a few weeks. Vaccines are safe.
Yeah, absolutely. I agree with that. I had less than 9. I don't know how you got 9 COVID shots already. I think I'm up to 6.
Yeah, you got to get it. You got to get a little.
You're double dipping.
No, they come out with a new vaccine. I'm like at the CVS the next week. That's where, and I got my vaccine, the first vaccine at Loma Linda, the first 3 days that they came out.
In December, I remember we were lining up.
That's why I've never had an infection, so I'm a vaccine believer.
We went off the rail. Sorry.
Yeah, I know. Any information that any of you can add to what you see in the future treatment of autoimmune hepatitis? People are asking, please tell us what's happening, what are the most recent development, and what is happening in near future.
So I think Bob mentioned Kezar's drug. That's exciting. I think I mentioned when I was closing that there was one drug that was a toll-like receptor 4, and that had promising results. That was out of Taiwan. That was 4 years ago, but another company recently bought them in 2022, and we haven't heard, but I'm optimistic that because the results were good, they're just ramping up to kind of roll that out as a phase 3. Zitozepsimib, so hard to say, Zeto, or Kezar 676 was the drug for Kezar, the Portola study, and that is an immune proteasome inhibitor that had some promising results, we think, but they haven't unblinded the data yet. So some of the patients did really well, but we don't know if they were on the placebo arm or in the control. And by the way, the placebo arm still got standard of care in that trial. So if you do end up doing an autoimmune hepatitis trial, you'll still be compared. It will be standard of care plus this drug versus standard of care plus placebo. So we're not going to put anybody on just placebo. The issue is right now, the trials are being done for people who are not responding. So that's the first phase usually in drug development.
One comment, if I can.
Yeah.
Every autoimmune patient that I see immediately goes on ursodiol. There's some interesting study from Japan that 20% of people who have autoimmune hepatitis on biopsy can get away with urso monotherapy long-term. So everybody's on urso, then I add mycophenolate and budesonide, and that allows me to get people off budesonide in 90 days in every patient. And then I push the mycophenolate to the right blood level, and these patients do extremely well. So urso, in my opinion, according to the Japanese paper and my last 60 or 70 patients, everybody's on urso.
I've never heard that, Bob.
Agree 100%, Dr. Gish,
So
with that.
interesting.
This is like the practice has been going on for several years, but some of the centers, they don't like the orthodile. I am a believer in orthodile. I was trained at UCLA, which is orthodile is a big issue there. We put every single patient after transplant or even before the transplant on orthodile.
Let's
Because
just make
like
it clear, we're not
we
giving medical
believe that
advice
this-
though, especially medical advice that's not in the guidelines, guys. There's no harm in ursodiol. And I appreciate your opinion, but just make sure you talk to your doctor first, because Bob, next thing you know, my patient's going to come to you and say, put me on ursodiol, right?
I'll send you the paper.
I'm sure there's one paper. I
It's a
believe you,
It's a
but-
great paper.
but I'm not going to change my practice based on just one.
Now I should change
But
it on that and my
Based on your
experience.
experience.
My
You should write up
expert
your
opinion.
experience, Bob. Write it up. Seriously.
We're
it
working
will.
on it.
Add to the literature. But honestly, there's not a lot of harm. It kind of in the same vein with drug-induced liver injury, when patients have like a cholestatic phenotype and they come in with like elevated OCT and it's a drug. In the US, we never put them on urso. I just had this discussion with a colleague of mine from France, and like over the liver meeting, it was like, well, we give urso to everybody. I'm like, it's so interesting. Some people have really low thresholds for giving urso, and for right reason. It's really not a lot of harm you can do with urso, especially at low doses.
Excellent. I'll send you the paper. I'll change it.
I know you're working on it in the background.
Please send it to me,
Looking away.
Dr. Gish.
So George, you're giving kids urso even if they don't have PBC?
We don't have PBC in kids.
Oh yeah, of course, right, of course. So you giving him urso?
We give like a PSCs, you get also autoimmune
Sure.
hepatitis, you get also.
So PSC low dose urso, I get it.
Yes.
But I didn't know if for autoimmune hepatitis without any PSC features, you still put them on urso at Children's
Yes.
Hospital LA. That's so
Well, I am the one, the other hepatologists, some of them, they don't believe in ortho. And this was the practice from before, like the previous hepatologist, he didn't believe in this medication. Even like with the transplant patients, they don't put them on that. But when I joined CHLA in 2009, I started like any patient I see, if I have to prescribe also for legitimate reason, I do it.
Well, legitimate reason is dog's injury, but like that's okay.
Look
This
in
is
your
not
inbox,
very-
Lily. It's already
Okay,
there.
I'll check my email. I just want to remind people, we're just shooting the breeze here. We're just chit-chatting. Talk to your doctors before you change your therapy or go on anything, especially.
But, and you know, this is the best part of our program that the patients love, because they get to see you guys talking with each other like
Yeah.
friends and talking about all kinds of things that we normally don't hear from doctors when we go to visit the doctor for whatever illness we have. Dr. Yanni, you have a personal question that I will have to send to you from one of our audience. So this is really all the time we have for questions. I want to thank again our participant doctors. We are grateful for our excellent experts who donate their time and talent and experience to help liver patients. We hope everyone received important and new information on this very topic that everybody was asking about for us to hold the webinar on. My personal heartfelt appreciation to our doctors for their kindness and compassion and time. Thank you, Dr. Dara. Your presentation was wonderful. We are grateful for your support tonight and look forward to many more years of partnering with you.
Thank you so
Thank
much.
you.
Thank you for inviting me. Thank you, Bob. Always a pleasure. And thank you, George. Great to hear you, because I didn't see you. Your camera was off.
Great to hear you too, and that was an amazing presentation. Thank you very much, everyone.
Thank you, everyone. Bye.
Thank you. Wait. We have a few more things to say.
Oh,
I want to thank Dr. Yanni Liver Health Foundation is very grateful. You have been supporting us in many ways, and we really appreciate it. Thank you, Dr. Gish. You are my go-to doctor. I know I can always count on you with great information. Thank you, Epson Pharmaceuticals, for the educational grant that made this program possible. I want to invite everybody to join us on November 26th for another educational webinar. This one is going to be on cirrhosis and complications from cirrhosis, including HE. Our speakers are Dr. Jeffrey Kahn, Dr. Hu, and Dr. Ayub from Cedars-Sinai and UCI. During the webinar, you will be also able to post your questions. Liver Health Foundation is on social media. We have website, we have YouTube. Please check us out. Thank you for joining us this evening for this important webinar. We hope to see you next week on November 26th for the Cirrhosis and HE webinar. We wish a happy and safe Thanksgiving for all. Thank you, doctors. We appreciate your help. Everyone, please be well, take care, and good night.
Thank you, Farah. Good night and happy Thanksgiving to everyone.
Yes, thank you.